Hi there, my name is Kurt Taylor and I'm a statistician for Patari Evidence, and I'm presenting this ISPOR poster on behalf of myself and my co-authors Anthony Hatswell and Ash Bullermont, and the poster is entitled The Dynamic Nature of Network Meta-Analysis, How Data Updates Could Influence Health Technology Assessment. So in health technology assessment, indirect treatment comparisons are required when direct head-to-head trials between treatments that are relevant to the decision problem are unavailable. So ITCs can estimate the relative effectiveness of interventions when a common comparator, for example, placebo, is available. And when a common comparator isn't available, unanchored approaches can be used. So network meta-analyses extend ITCs by synthesizing evidence from multiple clinical trials to estimate relative efficacy across a network of treatments. So at the point of HTA submission, clinical trial data are often immature or incomplete, particularly for newer treatments. This can lead to uncertainty in estimating relative efficacy, affecting decision making. Additional data from ongoing or new trials may alter conclusions drawn from an initial NMA. So this study replicated a previously conducted NMA from a past HTA submission, and we examined how the inclusion of more recent and mature data affects the estimated relative treatment effects. And the goal was to understand whether updated evidence changes the conclusions of the original analysis, which potentially could influence decision-making in HTA. A Bayesian NMA of overall survival in non-small cell lung cancer was replicated, which encompassed 8 treatments using publicly available documentation from NICE Technology Appraisal 557. An illustration of the treatment network is provided in Figure 1 of the poster, where you can see you have a star-shaped network with a couple of treatments off to the side, with platin plus PEM in the center of the star, which is essentially the placebo in this treatment network. So some point estimates were not included in the publicly available committee papers. So where necessary, the analysis was supplemented by estimating these redacted values from published data by searching the literature. So in line with the NICE submission, both fixed and random effects models were fitted. Random effects models were ultimately used in the economic model of the NICE submission and are therefore presented in this poster. And we conducted all analyses using R and using the multi-NMA package. So as I mentioned, not all of the results were publicly available within NICE TA 557 documentation. And so using information from the literature, the results were reproduced within very, very close proximity of those presented in the NICE TA. Newer data cuts were identified in the literature for just 2 of the treatments within the network. These were pembrolizumab plus pemetrexed and platinum, and pembrolizumab plus pemetrexed and carboplatin. And those are the 2 treatments at the bottom of the forest plot shown in Figure 2 of in the poster. After incorporating results from the most recently published data cuts, outcomes for both treatments relative to carboplatin plus pemetrexed attenuated towards the null. And the hazard ratio and 95% credible intervals for pembrolizumab plus pemetrexed and platinum versus placebo plus pemetrexed and platinum increased from 0.49 point estimate to 0.60 with the newly published data. So a 0.49 estimate in the original NICE submission to 0.60 using the most recent data cut. So it's quite a considerable jump. And the same trend was observed for the other comparator that had newly available data. And also the posterior distribution for pembrolizumab plus pemetrexed and carboplatin shifted, with the 95% credible interval now including 1. Which you can see at the bottom of Figure 2 there in the poster. So this change may have important implications for how HTA bodies interpret the treatment's effectiveness, given that the precision of the estimate now includes the null. The results of the current analysis demonstrate that incorporating more recent data can lead to meaningful changes in results, which highlights the dynamic nature of NMAs in health technology assessment. Seemingly small changes in point estimates of hazard ratios, like we've just shown here and discussed, can have a profound effect on cost effectiveness results, as these results are often fed into cost effectiveness models. And this can, of course, influence decision making. Additionally, publicly available information like that on the NICE website can be limited, hindering reproducibility, like we found here with some of the values that were redacted, which prevented us from exactly replicating the NMA and made us search the literature for those missing values. So these findings emphasise the need for updating NMAs when new data are made available, and for greater transparency in reporting and improved access to complete data to ensure that health policy recommendations reflect the most current evidence. And thank you for your interest in this poster, and hopefully discuss more with you soon.